Hi everyone, my name is Brian Forbes and I will be talking to you briefly today about my proposed study. Before we get started, I will tell you a little bit about myself, which will hopefully add some context to this presentation. I've been working for the last 8 years in Durham Region as an advanced care paramedic. Over my relatively short career, I have noticed a great deal of change in how patients are transported to the emergency room. Hopefully this is not the case, but if you have had any experience with paramedics prior to 2010, you may remember having the choice of which area hospital you were to be transported. This policy changed between 2010 and 2013, when the hospital destination was determined by the amount of patients already waiting in the emergency department. The goal was to reduce overcrowding in the more urban hospitals by transporting patients to outlying emergency rooms, which were typically less busy. The last redesign came in 2013 and is the system that is currently in place in the Durham region. Patients are transported to the closest, most appropriate facility regardless of the amount of patients already waiting. Despite recent changes in hospitals across the province, they continue to experience increased delays and emergency room overcrowding. What struck me as unusual was that despite the overcrowding and long waits, patients with very minor complaints were still calling for ambulance transport or making their own way to the emergency department for assessment and treatment. This observation led me to start thinking about ways we can better utilize the systems and resources already in place in our communities to help ease this increasing burden on the healthcare system. This brings me to my research question. Will the transportation of non-acute pre-hospital care patients to urgent care centers by land ambulances reduce emergency room wait times for acute care hospitals in medium-density urban settings in the Greater Toronto-Hamilton area? Now, before we get too far into this presentation, here's a brief overview of what you can expect to cover. Firstly, we will discuss the importance and relevance of this study and why I chose to investigate this issue. We will then review some of the strengths and weaknesses of the other literature in this field. Later, we will overview the study itself and talk about the objectives and methodology of the design. And lastly, we will cover some of the potential issues, concerns, and limitations that have been encountered throughout this process. I'm sure we have all observed the vast expansion of our communities and neighborhoods over the past decade or so. Populations continue to grow and age, often requiring increased access to a variety of healthcare services. According to the Canadian Institute for Health Information, Canadians make close to 16 million emergency room visits each year. Some of these visits are for serious and life-threatening conditions. However, some are due solely to lack of access to a primary care physician or alternative healthcare facility. It's estimated that nearly 60% of emergency room patients could be treated elsewhere. A government organization known as the Wait Time Alliance found that overcrowding in our emergency rooms across the country is not only affecting the patients with longer than average wait times when compared to other developed nations, but they have also reported that there is a notable effect on all levels of healthcare staff, whom report experiencing higher levels of burnout, stress, and fatigue. Emergency department overcrowding is also impacting the country's financial state, costing the Canadian government an estimated $14.8 billion a year. Existing literature in this field was limited, and a small pool of pre-existing research has been mostly executed under an American healthcare system. There was in fact only one Canadian study found to have investigated a similar issue, and its results determined that further investigation into this area was still required. A total of 15 articles met the search criteria and were evaluated for review. The majority of the studies in this area employed a hypothetical intervention in the form of a post-response questionnaire. Hauswald, Levine et al. And Silvestri et al. Employed this design in their investigations, whereby paramedics who would respond to a call for service, transport the patient to a traditional emergency room, and then after the call was completed, fill out a survey package to state whether they felt the patient would have been suitable for an alternative destination. These surveys were reviewed by a team of physicians and followed up with patients' progression throughout the healthcare system. Another US-based study by Schaefer et al. Utilized a cohort method to determine the effectiveness of alternative destination transport by paramedics. After reviewing the available literature, 3 common strengths and weaknesses became apparent. A common theme of strengths among the reviewed studies was centered on patient safety. As the majority of studies involved a hypothetical intervention, there was little to no risk to the patients at all. Ease of implementation and therefore adherence to the study protocol ensured stronger validity among the studies that were reviewed. and a multiple physician review adds to the control and internal validity. The first limitation noted across the reviewed studies was acknowledged by many of the investigators themselves, and that is of the relatively small sample size. Some patients declined to enroll in the study, and some of the investigations took place utilizing only 1 or 2 facilities, which appears to have limited enrollment and therefore potentially affects the external validity of the studies. Contributing to the first limitation is a potential lack of training by the participants. Although the protocol in the retrospective studies was easy to follow and had a relatively strong rate of participation, studies with a tangible intervention, like that presented by Schaefer et al., had some complications with adherence. There was no noted training or education phase in the methodology of these reports, which could also detract from its external validity, as subjects may have missed enrollment when applicable. As I previously mentioned, most of these studies reviewed employed a retrospective cohort method. The post-intervention data was compared to a control group consisting of similar patients from years prior. This may create unwanted variations in the data due to uncontrollable changes between the time frame of the control group and that of the intervention group. And lastly, and not necessarily a true limitation, but the majority of the studies that were reviewed were carried out under an American healthcare system. Again, this alone is not a limitation to the study itself, but in the setting of comparing these results and data for the purposes of my proposed study, there are slight differences that may not translate to a Canadian model. So overall, what do we know? The literature reviewed has shown that paramedics in the field can make good clinical decisions after an appropriate assessment regarding patient condition. Although some of the hypothetical interventions investigated by the studies that were mentioned earlier found a small degree of risk to patient outcome, the overall consensus is that given the alternative destination has access to an appropriate set of resources, there is minimal to no risk to the patient. What the research has failed to show is whether the redirection of non-acute patients to alternative facilities will in fact reduce emergency room wait times. In an attempt to address the gaps in this field of research, my proposed study will seek to investigate primarily if there is a link between the diversion of non-acute patients to urgent care centers and the duration of emergency room wait times. Some secondary outcomes that may add to the existing literature in this field would be further information on data on the paramedic's ability to make clinical decisions in the field, the effect on operating costs to the healthcare system, and the satisfaction of both patients and healthcare employees. Although these secondary outcomes will not be a direct area of study for this investigation, the proposed research will yield data that could be used as a starting point for future research in these areas. Before we discuss the methodology of my study, it's important to define some of the common terms and their context within this investigation. For the purpose of this study, an urgent care center will be defined as a pre-existing facility with at least one physician staff during operational hours and a support team suitable to the size of the facility. In addition, the urgent care center must have access to phlebotomy and basic lab values, as well as ultrasound, X-ray, and wound care. Wait times, as a primary objective in this study, are defined as time to physician assessment and will be measured through data collection at the receiving facility during the course of the study. The GTHA, or Greater Toronto Hamilton Area, encompasses the cities of Hamilton and Toronto, as well as the regions of Halton, Peel, York, and Durham. Lastly, the Canadian Triage and Acuity Scale was developed to classify the severity of patient condition and is used widely across Canada in both hospital and pre-hospital settings. It has 5 classifications of patient condition, each with a corresponding time recommendation to assessment. For the purposes of this study, we will be discussing the 2 lowest or least acute groups of patients, commonly referred to as CTAS-4 and CTAS-5. The recommendation for CTAS-4 patients is 60 minutes from triage to assessment by nurse and an additional 60 minutes until physician assessment. These patients can include sprains, strains, concurrent vomiting and diarrhea, chronic back pain, and asymptomatic headaches. CTAS-5 patients are considered the least acute group and it is acceptable to wait up to 120 minutes from time of triage to nurse assessment and an additional 120 minutes until physician assessment. Patients in this category may be experiencing isolated sore throat, diarrhea, vomiting, or chronic abdominal pain. Now that we have defined some of the important terms, we can discuss the proposed methodology of this investigation. Active paramedics in the GTHA will be provided with an education session and a copy of the study directives, detailing the inclusion and exclusion criteria, as well as the study protocol. Once the study is live, the proposed recruitment and enrollment directive will be as follows. After receiving a call for service to a patient in the catchment area of the GTHA, paramedics will determine the CTAS of the patient. Patients meeting the criteria for CTAS 4 and 5 will be given the option to transport to an appropriately equipped urgent care center. If the patient declines, they will be transported to closest emergency department, and responding crew will document the reason given for the refusal. If the patient agrees, a form will be provided for the patient to sign. Paramedics will notify dispatch of the activation of diversion protocol and transport the patient to the closest designated urgent care center. To ensure an even distribution of enrollment across various peak times and address some of the limitations noted in the existing literature, this study will be executed over a 2-year period with monthly alternation of the diversion protocol. This means that for 1 month, paramedics would be following the diversion directive, and the next month they would be following normal practice. The intent of this is to gain exposure to high and low call volume over a relatively short period of time while maintaining the validity of the study. The inclusion criteria would be as follows. Patients 18 years and older. Patient must be CTAS 4 or 5 as categorized by the responding crew. The patient is not anticipated to require admission to an acute care facility due to a pre-existing condition, such as renal failure or chronic obstructive pulmonary disease. Written consent must be provided. Patients will be excluded from the study if they are under the age of 18, if they're pregnant and over 21 weeks gestation, patients deemed to be CTAS 1, 2, or 3, the patient is a non-ambulatory resident of a nursing home or an assisted living facility, or the patient is an outpatient of a renal dialysis facility. And of course, if the patient denies diversion and requests transport to a traditional emergency room. The particular for this investigation will be the implementation of paramedic-directed diversion of CTAS 4 and 5 patients to urgent care centers. The primary outcome will be considered emergency room wait times and will be measured using a pre-post evaluation, comparing the intervention phases of the study against the control times. The secondary outcomes will be the financial impact on the healthcare system and the satisfaction of patients and staff, again measuring data present during the intervention phases against that of the control. The proposed hypothesis for this study is that the redirection of non-acute patients to alternate facilities will reduce emergency room wait times. The independent variable can be considered the implementation of the Alternative Transport Directive. The dependent variables would be patient wait times in the emergency room, operating costs to the emergency room, and patient and employee satisfaction. In terms of ethical considerations, there are no significant concerns expected during the execution of this investigation. However, as with any alteration to patient care, a small risk does exist that patient condition could change or progress after being transported to an alternative facility. As mentioned previously, existing studies have shown that this risk is quite minimal and is considered to be at a safe and acceptable level. To help address this concern, patients would be educated and informed and would be required to sign a release prior to the transport. Some of the potential challenges or limitations that may present during the execution of this investigation are the location and procurement of urgent care centers with appropriate resources and sufficient staff to accommodate the increased patient traffic. To avoid issues with compliance, the study directive must be clear and concise in order to ensure that paramedics will be diverting the appropriate patients under the right conditions. And lastly, patients may have some predispositions about the 911 system and calling for an ambulance that may steer them towards opting out of the study and choosing care at a traditional emergency room. This would have to be addressed with proper education and information at the time of paramedic contact to ensure the patients understand and appreciate their options, thus making an educated and informed decision about their care. I provided a list of references for you to review. Thank you for taking the time to view this presentation, and I look forward to your feedback and comments.